Standard microstructure of right hemisphere dorsal stream language tracts following rTMS plus high intensity speech language therapy and chronic post-stroke aphasia. In introduction and some terms, language impairment or aphasia is a common consequence of stroke. We looked at chronic post-stroke aphasia, which means aphasia as a result of stroke after 6 months. We looked at non-fluent aphasia in particular, which means that patients were able to comprehend speech but had difficulty producing speech. Additionally, rehabilitation interventions can promote neuroplastic changes in aphasic patients that may be associated with the improvement of language function. Prior research points to an improvement of speech production in aphasia after repetitive transcranial magnetic stimulation, where we use an electromagnet to basically stimulate the brain through shocks that either inhibit or activate parts of the brain, coupled with high-intensity speech-language therapy. Examining structural changes that occur following rehabilitation can help us better understand the neural mechanisms of recovery, so how the brain recovers and changes white matter structure to accommodate for what happens after a stroke and what happens with aphasia. Our methods: we had a randomized control trial with 20 participants, 15 male and 5 female. They were chronic post-stroke participants with non-fluent aphasia of a mean age of 62.7 years. Participants received 10 daily sessions of rTMS. 10 participants received sham rTMS, where the rTMS coil was not activated and did not stimulate the brain, while 10 received 1 Hz rTMS over the right pars triangulus of the inferior frontal gyrus. All participants completed 30 hours of speech-language therapy and pre- and post-intervention MRIs, which were 21 days apart. The primary clinical outcome measure was a Boston naming test, a confrontation picture naming task, where the correct number of spontaneous responses, i.e. without cueing or correction, was recorded. So we gave patients this test, they looked at pictures in a picture book basically, and they responded, and we recorded those responses. The diffusion weighted MRI, we took 64 diffusion encoding directions at a B value of 1,500, pre-processed and reconstructed using the tensor model in FSL, the computer program we used, and tracts of interest were isolated using anatomical constraints. As you can see from figure 1, lesion overlap of participants. So the lesion of the stroke in participants, the sham rTMS and active rTMS group had some differences. In figure 2, the sagittal view of the isolated arcuate fasciculus can be seen on the left, and on the right, the coronal view of the isolated frontal slant tract can be seen. In our results, we found that the mean fractional anisotrophy of the right arcuate fasciculus decreased between pre- and post-treatment scans across groups. Fractional anisotrophy measures the diffusion of water in the white matter tracts in the brain, and a lower value is closer to what a healthier patient will have, whereas a stroke patient would have a value closer and higher, usually near 1. Changes on the Boston naming test were not correlated with right arcuate fasciculus fractional anisotrophy change. And for the frontal slant tract, the mean axial diffusivity of the right frontal slant tract increased between pre- and post-treatment scans across groups. Axial diffusivity is another measure of diffusion of water in the white matter tract, where the value shows that there's diffusion outside of the tract. The changes on the Boston naming test were not correlated with right frontal slant tract axial diffusivity change. In conclusion, changes in fractional anisotrophy and axial diffusivity in the arcuate fasciculus and frontal slant tract show no group difference in microstructure, and changes in microstructure were not related to changes on the Boston naming test. The present study, therefore, does not support changes of speech production and aphasia as a result of changes in microstructure after rTMS coupled with SLT. Limitations included a short period between imaging, sample size, which was small, and differences in lesion area between the two groups of rTMS and sham rTMS. Future studies should include increasing sample size and time between imaging. This study was funded by the Heart and Stroke Foundation and Alberta Innovates Summer Research Studentship, and it was done at the Foothills Medical Center through the University of Calgary and Alberta Health Services.